Dr. Shaker, would you please unmute and share your screen?
Uh, Diane, am I sharing my screen now?
You are.
Okay, thank you. So yeah, I think I know many of you. It's a pleasure to be speaking, and I'm really happy people are on. I'm really even more curmudgeon-y to have to follow Neil because he always gives such a great talk. But I'm going to talk about what we do, what happens when drugs are stopped, and obviously the focus on Denosumab. I can't seem to make my, oh, there we go. So obviously my opinions, I have some opinions, and that's a potential conflict of interest. So let me start with a case that we'll come back to. A 70-year-old woman, osteoporosis diagnosed at age 60. She's not had any fractures. She did take bisphosphonates for a couple of years in her 60s, but then at 65 was diagnosed with breast cancer. She had a lumpectomy, radiation, and chemo, and was treated with an aromatase inhibitor, which she's going to stop now. And they treated her, the oncologist treated her with DMAB as they often do, and they were just going to stop it, but now they're getting a little more into that concern. And her last dose was 6 months ago. Her exam is okay. The workup is negative. Her T-score is minus 2.6. What next? So let's talk about staying on meds. How do we do? And this systematic review gives us how well we do with oral bisphosphonates. And you can look at 6 months, 12 months, 24 months. I think, you know, the range is wide, but we're talking about maybe 50% of patients stay on it. This is administrative claims discontinuation rate from Humana. And if you look at ZA, zoledronic acid, about 40% only get one dose. And about 20% only get 2 doses. Now, I don't worry about that very much because of the very long tail effect of ZA. With DMAB, it looks like about 50% of patients continue after 1 year and about 1/3 after 2 years. That's concerning. Now, there is I think if you're really careful about this, you can increase this. This was a paper published in Osteoporosis International, and it was from a private practice specializing in osteoporosis, and they really kept their eyes on these patients, and they were able to keep 2/3 on treatment for 3 years. So let me kind of quickly review what you need to do when you stop meds. And most of this is known. I'm not going to go over in detail. Anabolic therapy, you need to follow with an anti-resorptive or your gains will go away. Combined anabolic anti-resorptive with romosozumab, the same things. Bone loss occurs slowly after stopping bisphosphonates, and fracture risk increases a little over time. This kind of relates to the question that was asked a few minutes ago. Bone loss clearly occurs after stopping estrogen, raloxifene, denosumab, and adanicatib, which never got approved. And I've seen this quote, DMAB is just like other non-bisphosphonate treatment, like estrogen therapy, but because the bone density increased more with DMAB, it decreases more. Is this true, or is DMAB fundamentally different than hormone therapy? And that's a question that I want to address. So let's start with stopping alendronate therapy. And these people got 5 years or 10 years of alendronate. The doses were 5 or 10 milligrams, or it's kind of complicated. But the bottom line is, if you look at the top at urinary NTX when you stop it, this is baseline. It goes way down, and it comes up over the next 5 years, drifts up towards baseline. If you look at bone density at the lumbar spine or total hip, at the case of the spine, it stays stable, but I suspect some of this is just advancing degenerative changes. And at the total hip, it goes down. Well, how about fractures? And I've always thought this is in roughly 1,000 patients. I've always thought this was kind of odd. Clinical spine fractures over the second 5 years were reduced in the alendronate group. But morphometric spine fractures were not. And that's a bigger group. So I always thought it was odd that the clinical fractures were reduced in the second 5 years. Non-spine fractures, no different in the next 5 years. I want to talk a little bit about zoledronic acid. This is similar data. This is 3 versus 6 years. And and if you look at bone density at the femoral neck, total hip, or lumbar spine, the people in the dotted who you stopped after 3 years, their bone density slowly drifts down. Likewise, their markers of bone turnover slowly drift up, but don't get back to normal. And in this fracture analysis, they found that morphometric vertebral fractures were increased in the placebo group in the second 3 years compared to the ones that continued ZA for 3 years. But there was no difference in non-vertebral fractures or hip fractures. How about estrogen? And look at the red boxes. I think this gives the best information, and the dotted line. So these are people that have been on estrogen for a couple of years. They stop it, and within a year, the bone density has come down almost to baseline. And bone markers, again, the dotted line, come up towards baseline within a year. So how about fractures? The Women's Health Initiative had a group of patients that had no hormone therapy in the follow-up period. And basically what they showed in following these patients was that the fracture benefit went away very quickly. There may have been a slight benefit in this group where you see the fracture line. This is the prior estrogen alone group, and the bottom is total fractures. But I think for practical purposes, the fracture benefit goes away pretty quickly, certainly within 2 to 5 years. Now, how about DMAB? So I think this is the dilemma that we're all faced with now most of the time. So whether you give DMAB for 2 years, 8 years, or 10 years, when you stop it, bone density comes down very rapidly. And in fact, if you look at these people who had it for 10 years, at 1 year later, their total hip bone density was less than baseline, even though it had gone up 8%. So bone density drops very rapidly when you stop denosumab. Further, this is bone marker data. As you can see, bone resorption marker goes up, the CTX goes up well above baseline when you stop it. There's a rebound, and that rebound increase in bone resorption and bone turnover markers persists for a while. So when you stop DMAB, markers go up and bone density goes down. There are several reports of clusters of spine fractures, and presumably this is because rapid bone loss is really bad and you get microarchitectural deterioration. There are even reports of bone resorption so robust that hypercalcemia occurs. Now, most of this has been in children with either fibrous dysplasia of bone or giant cell tumors, but there have been reports in patients with osteoporosis, and I have seen one patient who developed mild hypercalcemia after stopping denosumab. There's a very recent observational study when they looked at DMAB delay more than 16 weeks compared to continuing on it. The hazard ratio for vertebral fractures was about 4. And longer duration of DMAB appears to be associated with greater bone loss. So how about this post-DMAB study? Now, this is a complicated study, and I think you have to kind of dig into it a little bit to understand it. At least I did. They have, between these two groups, about 1,000 patients who were on DMAB from either 2 to 5 doses or 2 to 19 doses. And the median follow-up after a missed dose was 0.6 months in this chunk and less than 3 months in this chunk. So let's just say less than 6 months. And then they had roughly 500 patients who were in the prior placebo group. And if you look at during this follow-up, the number of vertebral fractures is equivalent to the people that were prior treatment and prior placebo. But the proportion of patients with multiple vertebral fractures was higher among those who discontinued DMAB, 60% versus 39%, corresponding to 3.4 and 2.2% risk of multiple vertebral fractures. So my interpretation of this data is that if you stop DMAB after a wide range of durations, the vertebral fracture is no different than if it was never taken within 6 months of a missed dose. And the risk of multiple vertebral fractures is greater than if it was never taken within 6 months of a missed dose. Further, the follow-up on this was less than 6 months, which really makes me concerned that the follow-up may not have been long enough. Why might that be? Well, I think it's important to recognize the difference in the way bisphosphonates and denosumab work. Bisphosphonates cause osteoclast apoptosis. They just die away. Denosumab impairs precursor differentiation predominantly. And you have a bunch of baby osteoclasts that keep building up the longer you're on denosumab. And once you take that break off, they race through maturation and start resorbing bone. So this is an editorial from Mike McClung, cancel the denosumab holiday. And so what do we do? We can not stop it, just continue it forever. And this is data that shows that, bone density goes up for 10 years. But I have to admit, I have some concerns about a very potent anti-resorptive drug indefinitely. How about changing to teriparatide or abaloparatide? Well, this is from the data switch study, and basically the red line is when you change to teriparatide, and basically bone density goes down rapidly when you do that, and bone turnover markers go up very much. So you're almost like pouring gas on a fire. So that you're not going to do that. So how about changing to a bisphosphonate limited course? So let me show you the data that I could find on this. So this is one study that's frequently quoted. And what they did is these are patients who got denosumab for 1 year and then were given alendronate for a year, and they had stable bone density in that second year. I think it's really important to recognize that that was only 1 year of DMAB. And I would not generalize this to longer courses. And how about resedronate? So this is a very small study. These are 3 patients who got DMAB for 2 years, basically. And these 3 got nothing. And you can see at the end of that next year, bone density dropped dramatically. And 5 patients got resedronate, and maybe the drop was a little less. I don't know. But certainly not, you didn't certainly hold on to the bone. Also, there are a handful of case reports of patients who got bisphosphonates orally after DMAB, published in the last couple of years, that show some of these patients with multiple fractures. In this first report, they got alendronate, 2 women. They had received 7 and 6 doses of DMAB, and then one got 3 and one got 9 spontaneous fractures on alendronate, and another similar patient who was treated with resedronate. How about ZA? Now, this is complicated. There are several slides I'm going to go through. This is all the stuff I could find. I may have missed some, but I think this is most of it. So this is from Ian Reed, and what they did, these are patients who were treated with DMAB for 7 years, and then got a dose of ZA 6 months after the last DMAB. And what they found was that over the next 2 years, they lost a lot of bone. And the concern was, this just doesn't work. In a subsequent study, the same group, and this is actually from that same study I showed you a minute ago, with people that got DMAB for 2 years, gave it 8 months after. And this seemed to be a little better. And the theory is that you have to wait until bone remodeling wakes up. And then if you give the ZA and bone remodeling wakes up, the ZA can get into the bone and decrease bone resorption.
5 minutes.
Thank you. So I'm going to go through a couple other slides quickly. These are patients who got a mean of 2.2 years of DMAB and got up to osteopenia. Some they treated with ZA, and some they gave another year of DMAB and then a year off. And the people who got the DMAB went up again and then came rapidly down. and the ZA stayed kind of stable. But some of the patients who got ZA had decreases in bone density. About 10% of the patients who were off that year had compression fractures. Um, I'm going to skip this one and go to this one. So this is 1 year data from a 2-year study. They had 61 patients who had received DMAB, and they randomized them to 3 groups. One just giving ZA at 6 months, the others monitoring CTX and giving CTX a little later, and another even a little later, or only if their bone density dropped, and then at 12 months if it didn't. Bottom line, bone density decreased in all groups, and a second treatment was needed in a third of patients, some at 6 months. So obviously, changing to a bisphosphonate limited course is the best choice. I think there's limited data with oral or weekly. I don't think oral will be effective in people with long courses. Zoledronic acid, timing may be important, may need multiple doses, and an advantage might be compliance. I think that my opinions on this, you need to monitor bone resorption and bone density. And when you start a patient, you have to have an exit strategy or a non-exit strategy. So one of the things that's come up that's pushed the use of denosumab is that, changes in bone density predict changes in fracture risk. And, you know, in the old days, we used to say, no, it's really just a minimal thing, like this study from 2002. But now there have been more studies that have suggested this is really big, and even to the point of this recently published paper where they said we should use bone density as a surrogate outcome for fracture. And a commentary by Ian Reed made the point that, you know, the error bars around that are pretty big, and it may lead to us using drugs based on bone density that don't have greater fracture risks. So this is this whole treat to target paradigm where you want to push the bone density up, and the first thing, use anabolics early. Your first choice anti-resorptor is denosumab, and then follow that by bisphosphonate. And you know, I know this is what many of the real smart people say. It's not my opinion. There's really no evidence that I know of that DMAB decreases fractures greater than ZA. ZA is easy to use. You don't have to worry about patients missing a dose. Lower cost. In our hospital, I'm told a year of DMAB is 4 times the price of a year of ZA. And there's this question about decreased mortality with ZA. So my opinion about the treat to target is we probably should be using anabolics earlier in high-risk patients, but I'm not convinced of advantage of DMAB over bisphosphonates, particularly ZA. So let me summarize. Teriparatide, abaloparatide, and Romo should be followed by anti-resorption, an anti-resorber. Bisphosphonate cessation is associated with slow bone loss and return of bone resorption to baseline. And the fracture risk probably increases slowly. It allows us to do holidays. I know there's controversy about that. It's my bias to do it. Bone loss occurs after estrogen and raloxifene withdrawal, and fracture benefit is probably lost within a couple of years. Bisphosphonates prevent that loss. DMAB cessation is associated with rapid bone loss and rebound increase in bone resorption above baselines, and multiple compression fractures have been reported. Benefit is lost very quickly, and vertebral fracture risk increases quickly. The longer duration of DMAB may be associated with greater bone loss. In my opinion, this is fundamentally different from stopping hormone therapy. And reasons I say that are there are reports of hypercalcemia after stopping DMAB. Standard bisphosphonate therapy does not reliably decrease bone loss after DMAB, but it does after stopping estrogen or on aromatase inhibitors, and in early menopausal women. And if you look at the HERS and Women's Health Initiative, millions of women stopped hormone replacement. We didn't see cases of multiple vertebral fractures like we see with stopping DMAB. So you may get this rebound increase. You need to use bisphosphonates. Timing may be important, and you need to monitor bone density and bone resorption marker. And I think you have to have an exit or non-exit strategy when you stop it. You might tell the patient you're going to take this for the rest of your life. That's a non-exit strategy, but you have to plan that in advance. So let's go back to this case. The options are putting her on an oral bisphosphonate, giving her ZA at 7 or 8 months, giving her ZA based on CTX going up, but I wouldn't wait longer than 9 months, or continuing DMAB. Based on my interpretation of the data, I would consider ZA at 7 to 8 months or use of oral alendronate. If I gave her ZA, I would do fasting CTX in 6 months and give ZA if, I don't know, certainly if it's greater than the midpoint of the premenopausal normal range, but if it's going up significantly. And I just want to finish with this. I put this in the after visit summary and go over this with any patient I put on DMAB. Yeah, I talk through the normal stuff, but I also talk about this increased bone resorption and clusters of fractures after stopping. And I explain that it's given every 6 months for osteoporosis, and Prolia doses should not be delayed or missed. And I also tell them if they want to stop DMAB, they'll need a bisphosphonate. So thank you, and I'd be happy to answer questions if there are any.
Yes, we have a few questions. Dr. Karen Hansen has a question and a comment. I'm interested in how or whether you use the FRAC score and or the number needed to treat table generated by Dennis Black in the post hoc analysis of FLEX 5 to decide whether to recommend a drug holiday. I look at both scenarios for each patient, but have sometimes run into conflicting conclusions.
So I think, Karen, that's a great question. I think this whole thing about drug holidays, so I can tell you, if I think a patient is so high that I can't stop their oral bisphosphonate after about 6 years or IV after about 4 doses, I'm probably going to put them on an anabolic. And I rarely continue them longer than that. And I typically, this is not based on data, I monitor CTX, fasting serum CTX and bone density, and use that to inform me if either the CTX goes up or the bone density goes down, I retreat them.
I like the idea of using CTX, but there, of course, there's a negative study from the same Dennis Black group showing that it didn't work at all to predict who would refracture.
Exactly. No, I know that.
Very frustrating. Very frustrating.
It is frustrating, but I agree completely. There is that negative study. That's why I say it's not data-based, but I think it's reasonable. And I am not comfortable with indefinite treatment with bisphosphonates. I think, yeah, I'll just say that, regardless of what the guidelines say.
I agree. I've just had some men at the VA where number needed to treat is pretty low, but then I calculate out their FRAC score and it's also kind of on the low side. And, you know, I basically present both pieces of data to the patient and ask what they want to do. But, and of course, most of them want to stop, of course.
Agreed.
Okay, another question. Are you aware of any bone histomorphometry studies done after denosumab discontinuation? Yeah, there have been, and I can't give the details, and I wonder if Neil might know these, but there is data of, you know, a lot of osteoclasts. So, and maybe, I don't know, somebody might know this data better than I do, but I know there is some data that shows increased osteoclasts. I think there was a paper maybe published in Clinical Endocrinology or European Journal of Endocrinology, but I can't remember it offhand. Somebody else, feel free to chirp in if they know the data. Okay, last question. Optimum timing of dental surgery on Prolia.
So I don't know the answer, but I can tell you what I do. I do it about a month before the next dose. And I would not hold doses for dental surgery. There is even a case report, a very interesting case report of somebody in whom it was held for a few months and the person had their compression fracture sitting in the dental chair getting the procedure done. I think it was published in Osteoporosis International. You remember that paper, Neil? So that's my bias. I'd be interested in what other people do.
We have a comment to Dr. Shaker's
Dr. Shaker's question about other people having data about ZA. This comment is other studies with ZA after denosumab include Anastasopoulos in JBMR in 2019 and Everts-Graber JBMR 2020 showing some benefit of zoledronate after denosumab. I think it's reasonable stopping denosumab after stopping denosumab. Okay. All right. And
Can I just say something?
yes.
Both those studies were included. One I kind of went over rather quickly, but I have both those studies are in the slides. The first one is the one that people got to the Greek study to osteopenia, and a bunch of them, the ZA prevented bone loss, but not in everybody. I think about, and one patient had a compression fracture out of like 27. The other study, I skipped, I do have that slide in there, but I skipped it. But it still showed that they lost, I think, about, even with ZA, about a third of the gain of, I wonder if I can find it, a third of the gain of spine bone density and half of hip bone, something like that. And if the person's there, maybe they can respond. But I have that, I had that in there, and I unfortunately, let me see if I can. Well, you know what? I'm just gonna say from the slide, okay? So and rather than
Sure.
in the Greek study, about 10 to 15% of the patients lost significant bone despite ZA, and when they extended it to 3 years, they said 20% quote relapsed into osteoporosis. That was just published in Bone, and in the Everts-Graber study, basically they lost, at a mean of 2.5 years, they lost 36% of the spine bone density gain and 51% of the total hip bone density gain. So it was still a significant bone loss. It was nowhere near, in my opinion, enough. And that's why they titled the paper Partial Conservation of Bone Mass. So I don't know if the person has any other comments, the person who brought those up.
I do have another comment. The person who posted that said, thanks for the reply. Another comment is, if the longer duration of DMAB, greater the risk of bone loss when it stopped. So does it make sense to do only a short duration of DMAB and switch to ZA? A quick answer, please.
Maybe. Sounds good to me.
Okay.